transforming the safety net in Los Angeles County. I've often heard that Los Angeles County should be considered a state or a country unto its own, and that there's policy that impacts California, and there's always Los Angeles County. So without further ado, I'd like to introduce Louise McCarthy, who's the President and CEO of the Community Clinic Association of Los Angeles County, where she represents the interests of LA area community clinics and health centers and those they serve. Welcome.
Great, thank you very much. And yes, it's LA, and I was chiding Annette a little bit before we started that she didn't include us in her examination of 5 counties. She doesn't have another year to complete the project, so doing a thorough analysis of LA just wasn't in the cards for that study. So if you saw the news this morning, you know that thousands of people are lining up at the Sports Center in South Los Angeles to get free care from volunteers. It used to be Remote Area Medical, now it's called Care Harbor, LA. And it's a real poignant picture of the need that we experience every day in LA County. So as I mentioned, or as was mentioned, I'm with the Community Clinic Association of LA County. We represent 47 nonprofit clinic organizations who run 145 full-time sites, serve nearly 1 million patients a year, and are doing this by hook or by crook with a real patchwork of funding. And we'll talk a little bit about that when it comes to where we're at now and where we need to be as far as innovation for the future. Our members recognize fully there's the promise and the peril of the Affordable Care Act in implementing health care reform, in that we have a model right now which is unsustainable, and if health reform is implemented poorly in LA County for any number of reasons, we will have a system that is absolutely unsustainable going forward. So one thing, when we think about what is innovation, I like that, you know, we actually had to ask ourselves, what is innovation? We think about these questions of innovation equals survival. Often, you know, you go to the science world and you look at species, you look at any number of natural phenomenon. Certainly, the recent release of the new iPhone is an example of innovation for survival. If there are no new versions, you will go out of business. The textbook organizations certainly know that as well. You have to put out a new version. It's a planned obsolescence. So we don't want to plan our obsolescence. We want to make sure that we're actually going to go forward. And we have a very good picture of what the opposite alternative is in LA. If you've been to the La Brea tar pits, this is my tongue-in-cheek look. If you can't read what it says, I told him to implement an electronic health record. So innovation is happening right now, and on the prior slide, in looking at sort of our mission and strategic vision, it talks about the evolving healthcare environment. We actually couldn't use the word system because that'd be an aspirational vocab word for LA, to call it one system. But we also recognize that we're not just innovating for one point in time in the future at which everything is suddenly set. It is going to continue to change. And so what we need to be is nimble and able to put systems in place that actually allow us to make transformation happen. So in thinking about that rapidly changing environment, well, prior to the CalSIM project telling us about how people behave under health reform, UCLA told us what they'd be eligible for under health reform, regardless of behavior. So this slide is the everyone does what they say they're going to do approach to health reform, which means that LA ends up with 800,000 remaining uninsured. We get 550,000 new enrollees into Medicaid, Medi-Cal in 2014. And then other folks get on the exchange, et cetera. So that's the rosiest picture. The CalSIM report, which is actually in your handouts, gives you 2 other scenarios. A base scenario, which leaves LA with 1.2 million uninsured, and an enhanced scenario, which whittles that number down just a little bit. So recognizing that this is the rosiest of pictures, as everyone gets full enrollment into the programs for which they're eligible, this is our goal. I'm going to ignore the base scenario for now because I have to be a professional optimist, and that's just the way it works. So where do the patients go, though? For LA's safety net, it was interesting to look at your slides from UCLA to see who is going to the safety net now and what's that proportion. It is different in LA. One, within our membership, 59% uninsured. 59% uninsured. That's far greater than other parts of the state and far greater parts than other parts of the nation when it comes to community clinics and health centers. Additionally, when we look at where people go in health reform, for LA's community clinics and health centers, we don't look at the exchange very much. We're looking at the Medi-Cal expansion. We're looking at the basic health program, whatever plan, whatever happens with that, because the vast majority of our patients are under 100% FPL. So that's where we need to spend the majority of our time really honing in and focusing in. So for the clinics, it's to say, where do our patients go? If they become insured, how do we retain them? And if they remain insured, how do we make sure that we can actually have a system in place that provides them some quality care and allows, sort of take the pressure off system-wide? And we are having these conversations, not just amongst the community clinics and health centers. We are doing this in partnership with the LA Department of Health Services, LA Care Health Plan, the Department of Mental Health, Public and Social Services, Public Health, probably forgetting 10 other departments, but that's about it. So thinking about where the patients go. And in that piece about thinking about the remaining uninsured, if we have, it's around 900,000 patients within our members right now, and we hit that ultimate target of 800,000 uninsured remaining in LA County, sure, by visit, by patient, we could provide them services, but it's absolutely unsustainable. We need to have, at a minimum, or at a maximum, 34.5% uninsured patient visits in the clinics. Anything over that, we need subsidies. That's not just buy me a new building. We need payment for services. That's why our low-income health program has been critical. Healthy Way LA, our early Medicaid expansion, has actually helped us fill that gap, make up the difference from 34.5% uninsured to the reality of our 59% uninsured. So that's been critical. And I want to make sure one key point is made about the Affordable Care Act. Yes, the community clinics and health centers are winners. They have won. There's been massive amounts of funding, actually new funding announced to improve cervical cancer quality today. To date in LA, $36 million has come into our members through the Affordable Care Act. Of that, $29 million is for infrastructure, capital. Those are not service dollars. Only $7 million are focused on services. So it's really important to think about, this is a major investment in infrastructure and creating the basket, but it doesn't create the services that need to go into that basket. So that's absolutely essential. So what is innovation? It doesn't have to be a big, complicated idea for it to have a huge impact. Basic ideas can be big ideas, especially in LA. Thinking about communication. Gosh, what if we actually talk to each other? I mean, it shouldn't be revolutionary. This is something that Amazon.com and Mac and everybody, Apple, everybody's been talking about for some time. They've been doing it all along. But imagine that we're actually able to communicate with each other and discuss a common issue amongst a common patient. What if it's even within our own organization where my mental health provider speaks to the primary care provider and they join forces to figure out how to better provide care? So I want to really put a caveat on when we talk about innovation, this isn't Apple innovation. We are not at the level. Safety net innovation is not Apple innovation. Safety net innovation is real common sense solutions that we just really need to build into our program when it comes to streamlining appropriate programs. Technology is a component of that, but without that core element of communication, innovation is not going to happen. So just some examples of what's happening right now. I mentioned the early Medicaid expansion, the low-income health program, AKA Healthy Way LA. To date, we have 200,000 individuals enrolled. We're over a third of the way to our total target enrollment for the Medicaid expansion in 2014. Unfortunately, we've been hazing them along the way, and so the experience may be one that a lot of the folks involved in the program want to get out. So just know that. The systems integration that's had to happen has been pulling together Department of Mental Health, Department of Mental Health, Public and Social Services, the clinics, and health services together to say, how do we build systems to enroll someone? Something so innovative as saying, we built one program, hey, DMH and DHS, maybe we should just use one enrollment form instead of enrolling them in the mental health benefit and enrolling them in the health services benefit. I mean, basic stuff, but real important. Looking at referrals. how do we actually get information on a specialty referral to the specialist and then get it back? I mean, this is kind of major stuff, but in the past, it has taken up to a year to get test results back on a specialty referral to a DHS facility. And that is not quality care. So we're working on that, getting those systems back in place. And then thinking about how do we pay for it? And how do we actually get out of just dicing up a limited amount of pie for our indigent care funding and look at whole person care, where dollars follow people as opposed to just allocating them to institutions. The other piece about this, and I want to recognize that there are funders in the room as well. Blue Shield is one of the folks that's really helped us with a lot of our work relative to data and talking about our integration and what we need to do. But also Kaiser Permanente has worked with us on a specialty care initiative. We have 80 organizations in 6 different coalitions who've tested out specialty care problems, and now they're focusing on best practices and spread countywide. Our Department of Health Services, with Hal Yee, who came down from San Francisco, thank you, San Francisco, is now convening 6 different groups looking at what are the specialty needs that DHS can fit across the county. And also, we're testing out for the first time e-consult. This is decision support. If I don't send someone to a specialist, I'm opening up a specialist slot for someone that really needs it. How do I get the decision support to be able to provide that person the care they need in the clinic without having to generate that referral? Basic but real important stuff. Decision support is critical. Specialists talking to primary care providers can be absolutely revolutionary when it comes to providing people care. And it really frees up system resources and frees up capacity for us to be able to deal with that 1/3 increase that Massachusetts experienced. So really thinking about that communication piece. But the lessons that we've had to date of innovation, you've got to be flexible. You've absolutely got to be flexible. If you're going to transform, you need to recognize that, like I said, it's a changing environment. There's a lot going on. You test things out, you plan, do, study, act. Do it over again. Phase in changes. Don't do it all at once. Starting July 1st with a brand new enrollment system that had only been marginally tested and for which we can't actually confirm people being enrolled in our Healthy Way LA program. Pardon me. Oh, Freud. That's key. But it's one of those things where if you do it whole hog, you better do it right. So test it first, phase it in, especially in a place like LA where we're this big, you've got to do it in chunks. And then allow for continuous stakeholder engagement, because if we're not able, and by stakeholders, those are the providers, those are the clinicians that are using the systems, those are the enrollment workers who are trying to navigate a new interface for the first time ever. And certainly it's the patient advocates and the patients themselves. So you have to allow for that continuous engagement, because they're going to be the people that tell you which way the wind is changing to make sure that you are able to plan for what the environment's going to look like going forward. So those are the lessons in a nutshell. We can talk more, I think, when we get to the general Q&A, but innovation's good, innovation's hard, sometimes it hurts, but hopefully in the end it will be for the better for all of us. So thank you.
Excellent, thank you so much. Questions, comments? Have you found any innovative approaches to embed cultural competency, linguistic competency within your healthcare system that you think have been particularly effective? Well,
when you look at LA's clinics and health centers, I mean, we've got 59% limited English proficiency within our member clinics as far as the patients go. And when you look at, I'm glad you mentioned the Armenians in the Valley, we've got various clinics are really centered around specific patient populations. So we have an Armenian clinic, we have a Korean clinic, we have a historic Chinese population clinic, Central American gay, lesbian, transgender clinic, and that's cultural competence there as well, recognizing that it's not solely just a language competency, it's one of culture. So what the experience has been in LA has really been that is ingrained into the development of the clinics. The challenge is getting clinicians that are able to do that. So that's why the team-based approach is so much more important. Having a good medical assistant, having a good nurse, having someone who can work with the patient and really be a cultural broker. Because with the primary care shortage being what it is, it's going to be a challenge for you to get that culturally competent doc. but you certainly can train an MA from the community.
Exactly. Now, and have you been able to find effective linkages with community-based organizations to partner with the clinics?
Absolutely. When we look at this and it's a sub-regional level for LA, we've got 8 different service planning areas, some of which are larger than some states. But absolutely, from faith-based communities to the Black barbershop in South Los Angeles, it's focusing on mental health outreach. There's a real wide array, and there's a high level of interest. So we're also seeing a lot of other providers recognizing the limits that we have for behavioral health services, for other types of outreach and enrollment and education. So partnership is key. If we didn't have it, we wouldn't be able to achieve the mission.
Right. Well, congratulations. That sounds very exciting.
Thank you.
Any other? Yeah, there's a question.
Yeah, thank you, Dr. Dismar. That was a brilliant presentation. I was just wondering, what short-term pragmatic techniques are you guys considering with respect to changes in the enrollment system under ACA, which will start either July 1 of next year or September 1 of next year?
So the short-term pragmatic solution to enrollment is a faith-based initiative, largely involving me going like this. But it's what we've got right now. We're going to have another, a couple 100,000 folks that we will still need to get onto Medi-Cal come 2014. For right now, our focus is how do we get the 200,000 that are currently on Healthy Way LA transferred over to managed care in 2014 seamlessly. So for us, it's really engaging our health plans right now to talk with them, because as it stands, our Department of Health Services doesn't even have a patient identifier to identify who these people are. So for us, we got to tie this thing up with a bow and be able to rework this. The promise of 2014, and I'll quote, Kim Belche, what she said to me is, don't worry about how it doesn't work now. We're going to rebuild it, and it has to be online, and it's got to be different. And so that's part of my faith-based, piece, is that it absolutely has to not look like it does now. If you have to walk to a DPSS office in LA, which could, multiple bus rides, you're not going to get enrolled. You are not going to get enrolled, and you're going to go to that clinic and say, just put me on the sliding fee scale. So it's taking that in-person level and that high intensity enrollment and bringing it down to something that, for example, a certified application assister at a clinic or an outstation eligibility worker can help someone navigate through, get on, without having to send someone to 3 places in order to be able to get them onto the program. The enrollment has been the biggest problem in our LAHP, and it's also the biggest promise for success. And that when they say it's going to change, I really have to believe it, because if it's not, we're sunk.
Yeah, quick comment. You alluded to the basic health plan, which is SB 703, which didn't make it out of the legislature this time, but I understand the author is going to deliver it into the special session, which starts in December. So can that bill somehow help this process?
Absolutely. We're really interested. We're very interested in the basic health plan, and from the community clinic standpoint, this is the plan where between Medi-Cal and BHP, that's where our patients are going to flow in and out of. Maybe in other parts of the state, folks are going to be getting enrolled in the exchange and going to health centers. That's different. But for us, it's that seamless integration. Once you make 134% of the federal poverty level and then you make 132, how do we follow you and your family between these programs and make sure that we can actually keep serving you as opposed to having you jump around? So for us, the BHP is a critical piece of legislation. I'll say that CCLAC was supportive of it, and we support that, and so I anticipate that we will if it's resurrected again.
Well, just a quick comment is that the exchange is opposed to it.
We understand.
And the administration appears to be opposed to it.
We understand, but we support.
Thank you. Our next speaker is Jennifer Knoll, who's the director for the Feather River Health Center in Paradise, and her topic is safety net issues in rural areas. Jennifer, welcome.
Thank you. This is a very short presentation. There's lots of issues in this area. Some of the rural communities, we have hospitals. Most of them are small-sized and 50 beds and under. And some are critical access hospitals known as CAHs, and they often experience lower volume than urban areas, but having a hospital within driving distance in a rural area is very important. Many rural communities do have hospitals, but some at least do have rural health clinics, federally qualified health clinics, and private practices that provide primary care within the driving distances of the rural health is also very important, and for our specialties. And then also the rural uninsured ages 0 to through 64. In the U.S. non-metro, we're at about 20%, and then the U.S. We're at about 17.5%. And who gets covered under the ACA? The private coverage through exchanges, approximately 16 million non-elderly uninsured, and most of them are employed. Our expanded Medicaid, approximately 16 million non-elderly uninsured, and half have income below 50% the FPL. 1/3 diagnosed with chronic conditions. The ACA and the rural is not a small urban area. Rural residents are more likely to engage in unhealthy behaviors, suffer from chronic diseases, be unemployed or low-wage earners, be uninsured, be over the age of 65. There are more provider shortages and outdated facilities in the rural communities. The Medicare payment changes, Part A for the providers, the reduced PPS hospital reimbursement, immediate and ongoing reductions in market basket updates, reductions in DHS payments start in 2014, expansions of low volume hospital adjustment, 25% increase for hospitals with less than 1,600 Medicare discharges, and located 15 miles, greater 15 miles road miles from another hospital within the 2011-2012. And then 3% bonus payment for rural health agencies between 2010 and 2015. Also other payment changes for the physicians. The Medicare payment changes, 10% bonus for primary care services furnished by primary care practitioners between 2011 and 2015, and the reduced geographic practice expense disparities. Medicaid payment changes, payment at 100% of Medicare between 2013 and 14, 100% of FMAP, and no increase in all inclusive rates, RHCs and FQHCs. The rural health workforce, expansion of National Health Service Corps, 1.5 million over 5 years, primary care residents training in RHCs and FQHCs, financial assistant grants, dental students likely to work in rural areas, public and allied health workers for mid-career training, school training, mental health providers likely to serve high-need populations, family nurse practitioners, expansions of nursing student loan programs. We, right now, just in our clinics, we have 22 mid-levels, nurse practitioners, family health, nurse practitioners and physician assistants, and we have 5 primary care physicians. So that's a huge need for us, is the physician portion of it. The delivery system reform, the bigger picture, quality measurement and transparency, comparative effectiveness research, value-based purchasing, care coordination and transition, patient-centered medical home. That's one of the things that we are definitely looking into, and that's where our physicians will play a big piece of that for us, is to be able to work with them. The accountable care organization, bundled payments, CMS Center for Medicare and Medicaid Innovation, $10 billion between 2011 and 19. Funded pilot projects, implement successful models. We are working with several grant writers. We are, for the research, we do a lot of patient surveys, working and comparing ourselves with other areas. So those are very vital to us, and just being able to, I think we share a lot of what Louise does in trying to get that changeover till 2014. Medicaid expansion, federal and state payment for Medicaid expansion. The numbers speak for themselves there. Medicaid expansion, local impact, new revenue for providers, expansion of capacity, services and jobs, case studies, impact on safety net clinics. We have been working quite a bit with just new ways to service our community. A lot of, we're working on a lot of home visits now. We're palliative care. We're partnering with, it's called the Esplanade House. It's a transitional area for families bringing them together. So we're working with them to get them the care that they need. So there's a lot out there that that we are working with, the mentally disabled care homes, working with them, getting them the care that they need, and integrated pain management, which is very big in our area. Future of ACA, RHCs were not implemented in the ACA except in one subtitle, which says that the FQHCs can subcontract with RHCs. RHCs do not yet know how we will be involved in the various aspects of the Act, including the Medicare Shared Savings Program and accountable care organizations. The move towards patient-centered medical home recognition is another aspect of care reform that RHCs are not sure how to accomplish given the increase of costs necessary to obtain the status. And we are working out those issues right now as we speak. The future, we do not know that if Medicaid programs expand to cover more individuals, that would very likely result in growth in our patient population, which could help provide more stability to RHCs in our efforts to serve our communities.
Excellent. Thank you very much. There's a question. Yes, sir.
You mentioned about the ability for FQHCs to subcontract with RHCs. Have you noticed any, have any of your RHCs noticed or been contacted by FQHCs in any level of, early discussions or more formal talks?
We have on very minimal right now, but I know that just in our area, we have been working with the FQHCs and trying to partner with them, because there are services that we don't have that they have and vice versa. So we are working with them on that.
Other questions?
Yeah, I have a question. The governor has called, and there's, I guess it's part of the Medicaid waiver, that there will be managed care systems set up in every county, including rural counties. And as we, most of us know around here, that managed care doesn't work as well in rural counties. In fact, the patterns of managed care seem to run counter to the patterns that are happening with respect to rural health care in certain areas. Do you have a sense of that as to how your constituency of the clinics are going to react and respond and participate in that effort?
We would like to participate in it if that's the way that, we have to go. In our areas, they have scattered very fast, the managed care, but we would like to be involved in it if it does come down to that piece. We definitely will want to be a part of that.
It certainly seems that dealing with older patients who have more challenging health care needs, fewer providers, greater geographic challenges, that you're really doing an amazing job and yet have a very, very difficult task ahead of you. I'm really concerned about the lack of the providers as part of that, because a lot of docs are old guys like myself, and the number of doctors leaving California is not insignificant. So this physician drain is really of concern. In view of that, have you found any innovative approaches about either modifying the current scope of practice or using multidisciplinary teams? Have you found any approaches to address the provider crisis?
We are looking into working with UC Davis Rural Prime, where the physicians, that's where they want to be, in rural areas. And so we're working on signing a contract with UC Davis to bring those third-year students, medical students, to our clinics to work and to help subsidize the physicians that way.
You know, this is, again, my personal perspective, but maybe during the discussion the panel might give their views on perhaps as we evolve and as we change and as we have innovative approaches, the whole concept of modifying scope of practice of various healthcare providers. It strikes me that with the technology and with the information, et cetera, that's available, I used to spend just hours and hours and hours of doing histories and even doing some physical exams, which were actually the same way that medicine was practiced hundreds of years ago. And I'm wondering, with all due respect to my colleagues who would probably string me up if they heard me saying this, but I'm wondering if we should really look at the future in terms of bringing how healthcare is really practiced in line and in view of the resources, the supports, and the information that's really available now as compared to what it was even 20 years ago. So I'd just like to throw that topic out for future discussion. But let's move on to innovations in California's public hospital system, just in time for 2014. And this talk will be presented by Dr. Susan Ehrlich, who is the Chief Executive Officer at San Mateo Medical Center, where she is a county, which is a county integrated healthcare system serving over 70,000 individuals annually. Welcome, Dr. Ehrlich.
Thank you. Thanks for inviting me to be here. I am the CEO at San Mateo Medical Center, but I wanted to mention a couple other hats that I wear because I have actually several unique and privileged views to comment on innovation. First, I'm the chair of the California Association of Public Hospitals Board, so I spend time with lots of other public hospitals and health systems. And I'm also a primary care provider. I take care of about 200 or 300 elderly people who have complex chronic diseases, so I still am spending time in clinic. So I have the privilege of seeing innovation from a statewide level and also from a one-on-one level. So my comments will reflect that. So I'd like to talk a little bit, not just about San Mateo Medical Center, but also about public hospitals and health systems in general, since I'm the only person here on the panel representing them, and talk about innovation and why it's important for the safety net. Some of what Louise covered is very much relevant and consistent with what I'm going to talk about as well. And then just to talk about how we're embracing innovation and give you some specific examples of what we're doing at San Mateo Medical Center that also reflects what other public hospitals and health systems are doing in the state. So first of all, there are 19 of us we're known as designated public hospitals. We're located in counties where 81% of Californians reside. Where most people are, there is also a public hospital. We serve, as a group, about 2.5 million patients annually with a whole range of services, and we provide about 10 million outpatient visits a year. We provide about a third of the hospital-based care to the state's Medi-Cal population and about half of all the hospital care to the state's uninsured. So we are actually essential to the safety net. If you didn't know that already, we definitely are. And a lot of what we do is provide high quality and culturally competent care. San Mateo Medical Center is one of the smaller public hospitals and health centers, but we're very important. We provide a fully integrated system of care, so emergency care, intensive care, medical and psychiatric care, and most importantly, and largely in our system, ambulatory care. We provide care to about 75,000 unique patients a year. This point is really important, so I put it up here. About 30,000 of those folks are impaneled to a medical home. This has been a major focus, not only of what we've been doing in the last half a dozen years, but also other public safety net hospitals. It says there in officially licensed 509 beds, but that really doesn't exactly describe what we do in acute care. It's actually a tiny proportion of what we do. The vast majority of those beds are skilled nursing. Most of them aren't staffed. So really on any day at San Mateo Medical Center, there'll be about 34 patients in our acute psych unit, about 31 patients in our med-surg unit, 6 people in our intensive care unit, and 32 people in skilled nursing. So we're actually perfectly positioned for the future because we have 11 clinics that provide 250,000 outpatient visits, but a very small inpatient service, which I think is really the vision for healthcare in the future. So here's an official definition of innovation. It even pronounces it for you there. The main thing that's important to understand is that we need innovation to address some fundamental problems with the healthcare environment. I like the fact we can't really call it a system. It's really an environment where we spend a lot of money in this country and we don't get very much for it. And everybody in this room knows that. One of the points that I wanted to pick up from Louise's talk is that innovation, when we think of innovation, we often think of Apple, or we think of something that's really high-tech and fancy. But the truth is that what we've seen, what we've even seen at San Mateo Medical Center, is that the real innovations that make big changes are really quite simple. So here's 2 examples of innovations, and one deals with telehealth. So this is one of those fancier kind of innovations, but I'll just describe an encounter that I had with a patient yesterday afternoon. Elderly woman in my clinic with many, many medical problems, but she happened to have a worrisome lesion on her back. And she was, of course, worried about cancer. So I brought over my trusty camera. Actually, my nurse did, in the spirit of working in a team. The nurse took a photograph of that picture, of that lesion. We loaded it onto the computer and sent it to our partners at UCSF, at San Francisco General Hospital. The dermatologist looked at the picture of the lesion, and by this morning, I had a response, a comment on the lesion in my electronic health record that allowed me to put my own mind at rest, put the patient's mind at rest, and not have her see the dermatologist. So that's an example of a very fancy thing that works really well in our system. A couple of very simple things. A few years ago, we started providing our patients with bags, okay, to bring in their medications. And by providing our patients with bags, they were more likely to bring in their medication, and we were able to reduce medical errors because they brought the bottles in. It's not enough to just get a list or something. You have to see the bottles and count the pills. So that's one very low-tech thing that allowed us to make a very important innovation. Another one that's been tested in other places, not just ours, is tape, okay? Ventilator-associated pneumonias are a big problem in hospitals, and they kill people. But if you increase the head of the bed to about 30 degrees, you can reduce the rate of ventilator-associated pneumonias. That's part of what we call a bundle of services. So what many ICUs have done is put a piece of tape on the wall behind the bed, showing where that 30% elevation point is. And through that innovation, along with the other things that we call the VAP bundle, isn't that a great term, we've been able to save lives. So simple and highly technical innovation encompasses it all. If you go to any healthcare conference today, public, private, you will hear people talking about high value. What is high value? High value is high quality at low cost. That's a very important concept for any healthcare provider, public or private, in this country today. In the safety net, we talk about high social value because not only do we have to increase quality and reduce costs, but we also have to provide access to populations of patients who wouldn't otherwise have it. So I really like this concept of high social value in the safety net that encompasses high value and the real mission that we have. Now, the waiver is a very, very, very important thing for public hospitals in the state of California. And one of the things that I think goes overlooked sometimes is that what the Bridge to Reform waiver, important title, what the Bridge to Reform waiver is an acknowledgement and an investment both by the federal government and the state of California in public hospitals and health systems. And it's basically a statement that healthcare reform will not happen unless we strengthen the safety net. So this has been a really important program for us. And it's very complex. We refer to the STCs, the special terms and conditions, all the time. But basically, it allows us to bolster our traditional safety net role in serving the underserved through the low-income health program, bringing people in who will be eligible for Medi-Cal in 2014. And then it supports innovation. And I'm going to give you some specific examples about that. Now, one of the things that the safety net, that the public hospitals have going for them is the California Healthcare Safety Net Institute. This is, oh my God, 2 minutes? You're kidding me. I have a lot to say. The Safety Net Institute supports us in innovation. So I want to give, let's see, I want to talk about one innovation because the other two innovations, electronic referrals, Louise covered, and what was the other one I was going to, care transitions. Lean is the Toyota production system, and this is what San Mateo Medical Center and 11 other California public hospital systems are using to really promote and become the language of innovation in our organizations. It sounds kind of funky when you talk about, the Toyota production system being the answer to quality in a public hospital system. But the truth is, if you look in this country and you look at innovative, high-performing healthcare systems, they all use some version of this. Lean Six Sigma, we all are doing it. And basically what it is it's a method of continuous quality improvement. PDSA cycles, Plan, Do, Study, Act. The key principles around it are that it supports continuous improvement, it promotes teamwork, it demonstrates a respect for patients and the healthcare workforce, and we basically study work in detail where it happens and use that information to make improvements. We've trained 52 leaders so far. We will get up to about 85 within the next 6 months. We've completed about 15 week-long improvement events that involve literally hundreds of staff and patients. And we do have patients on every single one of these work groups. And I have many very fascinating and interesting stories to tell about patient involvement in these because they make a big difference. So if you want to flip through the slides, you can see our work in care transitions, which basically is focused on reducing admissions to the hospital. E-referral, which is also another really important example of innovation that Louise talked about. And in conclusion then, we have to innovate using a lot of different practices, both high-tech and low-tech. We're already involved in innovations, and our waiver basically obligates us to do this because we have funds at risk to innovate. And the speed and pace of change is so fast, I can't even really describe it. I'm happy to answer questions.
Excellent. Thank you very much for the excellent talk. There's a question there.
I've been learning more recently about the Kaiser Labor Management Partnership and the unit-based teams and a lot of ways that it's working. And I was wondering if you would comment on the ways in which there are formalized or, informal labor management efforts within the public hospital system. And does the lean process incorporate that? And to what extent you're reaching to unions as partners to try and support the transformation process?
I'm not sure if the folks in the back of the room, would you mind just kind of repeating the question?
Right. I'll try. Basically, the question is about official labor and management partnerships and how those partnerships work with the lean process. So I will say that we don't have a formal labor management partnership, but we have many informal ones, and we're completely unionized. All of our staff are, including our physicians. So we work very closely with AFSCME, SEIU, CNA, and UEPD. It's just part of the fabric of what we do. So though we have not had a formal partnership of the type that you described. We have informal partnerships, and they, the unions are supporting that work that we do with Lean. And whenever issues come up, we have meet and confer sessions and spend time talking about it. We have a session coming up with our various labor partners to talk about healthcare reform and the types of things that we're doing. So I would say those partnerships are extremely important, and we try to nurture them as much as possible.
Most doctors, when I was practicing, which was a while ago, they never liked to be told what to do, particularly by patients. Have you found that your colleagues are more receptive to the Lean process and you know, that whole type of feedback?
Yes. I would say that even my own thinking, but definitely the thinking of the providers around me has really changed with respect to what it means to really involve patients in care. You know, first of all, I don't think, I'm just speaking generally for the medical profession, I don't think we ever felt that patients had a voice. Now I think we really feel that we can't provide care unless the patient's voice is strong in the room. So when we have these improvement weeks that we have with Lean, one of the basic ground rules is that everybody's voice in the room is equal. And those patient voices are, I can't imagine doing the work we're doing without them anymore, because they really bring a reality to the situation that you cannot capture in any other way.
Well, congratulations. That's very impressive if you're able to pull that off, and it sounds like you are, so congratulations.
Thank you.
Yeah, we've had really 5 great presentations, and I think it would be good for us to acknowledge that and part of the audience. Okay. We'll proceed.
Oh, okay. Well, we have a cleanup hitter, so to speak. And we have Ms. Melissa Schoen, who is on the agenda, noted as the reactor, so I'm looking forward to really a dynamic presentation. Ms. Schoen is an independent consultant working with foundations and healthcare safety net organizations to improve access to high-quality healthcare. Her skills, among others, include change management, strategic planning, organizational transformation, and operations improvement, all the things that are necessary to implement the great visions that we've heard today. Thank you so much for being here.
Thanks. I am really excited to be here. When Karen asked me to be part of this, I was so excited, not just because I knew we were going to hear really the key issues from these folks, both from an academic and data perspective, but also from on the ground, but also the fact that it's just such an exciting time right now. Hearing safety net organizations and hearing people talk about transformation, new models of care, innovation, learning how to pronounce it, innovation, is really an exciting time. And so how do we continue this momentum? How do we use health reform to really support those providers that are providing care to the underserved and really build off of the momentum? I think safety net organizations are really poised with their models of care to be able to address a lot of the challenges. There's a huge amount of opportunities, but we know, as we heard today, there's a lot of challenges out there as well. So some of the themes that I've been hearing both in the field and today, I think Susan just touched on that, this issue of value. So how do you continue to provide high quality care, but at a lower cost, at an affordable cost, at a reasonable cost? Annette talked about integration, collaboration is critical. Being able to provide care at the right place, not duplicating efforts, but really coordinating across the safety net. And I would also say not just within the safety net, but collaborating outside of the safety net. It needs to be health system-wide, environment-wide. With ACOs, safety net organizations need to be involved in that. So you need to be thinking about how do you bring safety net organizations into the collaborative efforts that are not just within the safety net. I think several people talked about care coordination. Again, efficient use of resources. You really have to, with those very complicated patients, you need to be coordinating across the different systems of care. So how do you do that in a way that's effective, efficient, and best for the patient? And so the patient is really key. We were talking before with the panel members about we have great representation here. there's no patients. We cannot forget about the patient. Patient engagement is critical in all of this. We talked a little bit about patient-centered medical home, but really bringing the patient in, there's data now showing that when you bring the patient in, it really does improve quality, but it also is, they're finding lower costs, lower utilization, appropriate utilization when you bring the patient in. So patient-centered medical home, not just meeting those requirements, but really engaging the patient in their own care. And then population management. I think some people were talked about it a little bit, but really thinking about there's some very complicated patients out there. So how do you really identify those and provide appropriate care for those very complicated patients? And think about how you're providing care across a population. And think about that much more broadly. Again, I think safety net organizations do this a lot and are very poised for this. And you see that already happening quite a bit, using data to start identifying those very complicated patients. I think within value and that the high quality, lower cost, we also heard a lot of talk today about access. Access is going to be incredibly important as healthcare reform comes in. We heard about from Dr. Wallace about the increased demand and what we've seen in Massachusetts. How do we help the safety net increase their capacity and increase their access? I think the coverage and eligibility, Louise talked about, I mean, the complicated issues around getting people enrolled. So not just identifying the people that are really eligible, but getting people enrolled and then tied to their medical home. So how do you go through that process? Streamlining the systems of eligibility, building off of some of the local efforts that are already happening. Some of the community health centers and other safety net organizations are already doing a lot around helping with eligibility and enrollment. So how do you help that? How do you use technology? I heard somebody talk a little bit about using technology for eligibility and enrollment, and that's absolutely critical. And then the language issues are going to be critical. How do we get the information out to those that maybe have English as a second language? And then several people talked about the access to the system within the safety net. So care teams, how do we enhance the providers? We know we're not going to have enough primary care providers to go around. They're already stretched in the safety net. So how do we really think about the workforce? Lou talked about that. We have to be using our workforce better, in better ways within the safety net. So care teams, new models of care, engaging patients in new ways. They don't always need to see a doctor. Sometimes a health coach or a nurse or an MA is actually a better source of care for them depending on what they need. So how do we support that? And how do we make sure that that is happening and is effectively happening in the safety net? And then technology. E-consults was talked about, telemedicine, electronic visits. I've been working with a couple of clinics that have implemented patient portals. They actually can't keep up with the demand for enrolling in patient portals in the safety net. People want access to their providers, and they don't always want to go face-to-face, and they're willing to use technology to do that. Telemedicine, Susan gave a great example of a way that that can help increase access to specialty care. Louise talked about sometimes you don't even need to see a specialist if you can just have that e-consult. So I really think in leveraging technology to enhance the capacity of primary care providers is going to be absolutely critical. So ways to do that, ways that we can support kind of these things of value, access, high quality care at a lower cost. Everybody talked about payment models. Payment models are a huge issue. We need to move beyond in-person, face-to-face visits with doctors. That's how people are getting paid now, and that's just not the way future care is going to be provided, and care, frankly, isn't being provided that way in a lot of safety net organizations where innovation is already happening. They're moving beyond that. So how do we support that with appropriate payment models and support really the innovative practices that are starting to happen? Right now, there's disincentive to be innovative because you're not getting paid in that way. So the payment models are absolutely critical. Technology implementation also, again, incentivizing that. There's so many ways to use technology. Safety net organizations are already implementing EHRs, are starting to use, I think, are using telemedicine at a much broader rate than the rest of the healthcare system. So how do we incentivize that? And how do we make sure that that keeps happening? And we don't, it's actually now disincentivized, frankly. And then Annette talked a lot about this flexibility to support local models. There's a lot of things happening at local levels that are really critical and are going to be critical for future models. So how do we build in flexibility into any kind of policies to be able to support what's happening at the local level and at rural versus urban? There's a lot of different needs, so you have to build in that flexibility. I think it's just, again, an exciting time. I know we have a little bit of time for questions and discussion. We were having great discussions before. The energy that is out there, the energy that's happening around the safety net is incredibly exciting. And I just really encourage everyone to think about how do we build off of that and how do we continue that momentum.
Great wrap-up. Thank you so much. Yes, sir.
I don't have a question. I have a comment or a recommendation. I want to compliment the presenters on trying to think innovatively and creatively amidst these grim times, because the grim reality is that the health protection is being slashed by the governor, and by the legislature, and in Washington, and so on. I have a recommendation that a presentation about these critical issues be done to the governor and the legislature when it reconvenes in December, and point out the absolute necessity for additional funding in order to carry out these very creative and imaginative and inventive and quality innovations. Without that, you're not going to be able to achieve the things that are necessary for the people who are fallen through the chasm, not the safety net, through the chasm, because that's exactly what's happened. Here in Sacramento County, all of the health centers were closed except for one on Broadway in Stockton. The mental health services went down the tubes. You know, child protective services went down the tubes, et cetera, et cetera, et cetera. And I think we have to use ourselves and organize aggressively and point out the critical need for the legislature and the governor to do its job.
Thank you. With all due respect, I can assure you that my boss, Senator Steinberg, would certainly agree with you in terms of the importance of these issues. And I think the question that he would ask is and solicit your involvement, engagement, and support is, where is that funding going to come from?
Well, it has to be explored, and I recommended to the governor last year, and to Steinberg, and to Perez, and so on, that there are critical areas that have not been touched.
You know, if I may, I'd actually like to say that I think it's important for folks in the healthcare safety net and beyond to think about our structural budget and to get just beyond healthcare and to talk about budgeting structurally. For example, the clinics statewide are in support of the proposition, which would close some of these tax loopholes and really sort of address, without which there would be slashes to education and other critical services. We can't let education lose in favor of healthcare, because where does our workforce come from? So I think it's something that the special session can certainly deal with, but for us as healthcare providers, as members of a business community, for every one provider that we hire 7 FTEs. We're economic generators in our communities, and we actually have to be coming to the table, not just to talk about healthcare and don't cut us, but to come with solutions and actually say, you know, is it time again for the California Forward and other folks to talk about the various, 24 different components of budget reform, tax reform, and other issues that might not say health in them, but if we don't address them, they're going to absolutely have an impact on healthcare.
Yeah, let me comment as well that I pointed out, and it was pointed out by at least 2 of the presenters, that most of the new dollars I think that are going to happen in healthcare over the next few years are going to come out of this federal initiative. Okay, therefore the state, all state agencies, community clinics, public hospitals, so on and so forth, and the governor himself have to take leadership in terms of fighting for every single federal dollar we can get. Okay, we're literally talking, for instance, just on the community clinic side, there's $11 billion over 5 years that will be newly available, and I'm sure
it's already been spent.
It's already been
gone.
Well,
it went into infrastructure only.
We're only 2 years into it. Okay, and we would hope, for instance, that the clinics would be able to get their share. That being somewhere around $1.5 billion over 5 years. Okay, and so I think the governor and the state agencies can help that process. but certainly the legislature, I think, has more work to do. It just isn't the exchange, and it's just as in Medi-Cal. There's all the provider communities working together with the various stakeholders that work in this capital every day, and leadership, Darrell Steinberg and Assembly Speaker John Perez. So there is a process, there is opportunities. I don't believe we're going to have a bad state budget forever, and I think this initiative, the economy is turning around, and I think this initiative on Prop 30 is going to help turn the tide.
Can I just dovetail on that comment and mention that a lot of the integration initiatives I was highlighting were funded by the private sector, our private foundation, Blue Shield, Kaiser, and they do a lot for clinics in this state, wellness, the endowment. I don't want to miss any, I don't want to offend anybody here because I know they're here, but they really are our partners in this, and it is a public-private kind of partnership, both in implementation and funding and decision-making.
Let me also add just real quickly, under the Affordable Care Act, there's prevention money also that we haven't really spoken about, and that's coming through county health departments, but also has a big impact on the safety net. And if you want to think about innovation, think back to the 1960s when the community health center program was started. And community health centers were actually given catchment areas and told provide all the services needed in that catchment area. Now, we've moved to a reimbursement model. Maybe we'll move back out of that, and community health centers can get more involved in keeping people in their communities healthy by helping with nutrition. So some community health centers let their parking lots versus having to be driven to school, or being involved in local planning for safe routes to school so kids can walk to school versus having to be driven to school. And St. John's Family Health Center in Los Angeles has a good model of what they call social medicine, and they document the social conditions that are causing problems in their clinic, which includes things like cockroaches in slum housing that leads to asthma. And so then they work with the city attorney to actually improve the slum housing versus simply giving kids inhalers. So there's a lot that we can do. There's a lot of focus on, well, we've got to keep the trains on time and trains running, but if we sort of break out and think a little more innovatively, we can do a lot more in the safety net as well.
I really think Louise made a very, very important point, and again, from a personal perspective, I have a 19-year-old son with autism, which is kind of how I got from cardiology to this area. And I know that very often individuals with disabilities, underserved, and special health care needs, very often I think we feel like we're fighting over the crumbs, that we're around the edges. So I think to the extent that we can coalesce, pull together, and look at this from a global perspective, I think it's really going to lead to where we all want to go to, and it's going to help all of us and help our state as well. Very often, improvements and innovations that will assist the underserved and the most needy are actually systems change that can help all of us. So thank you for your comments. There was a question in the middle or back of the room, and then we'll take the question up here.
It's a little wonky. It's for Dr. Ehrlich. Kathy Hoffman with the California Medicaid Research Institute. The Bridge Health Reform waiver now is, approaching 2 years into its implementation. And the public hospitals, to their credit, really scrambled to put together milestones, metrics, so that they could be financed for some pretty amazing innovations. And I remember sitting in on that process and thinking, boy, there's some hospitals that these are going to be pretty, these might be slam dunk, and there are other hospitals that these are going to be incredibly ambitious. And if they don't make it, what's their funding going? And I'm wondering if you would update me on the variation you're seeing in our public hospitals being able to hit their milestones and get their reimbursement?
Yeah, that's a great question. So one of the things that I didn't have a lot of...
Can you repeat the question for the
yes.
TV audience? Because
yes.
we maybe
so the question had to do with the Medi-Cal waiver and all the projects and milestones that the public hospitals have set for ourselves and where we are. It's a great question, and it's very timely because on September 30th, we're required to submit our second year annual report. So I'm really eager to see that and to see how we're all doing, because I think California public hospitals, for a variety of reasons, are really linked together. One of the ways we're linked together is I think we have a responsibility to really make good use of the money that we have at risk under the innovations waiver and do a lot with it, and we really are. and I'm eager to see the data that supports that. You did raise a question about some of the milestones being slam dunks and some of them being more far-reaching, and that is an issue that's come up. But for me, it's really about the fact that each public hospital over the 5 years has 200 milestones on average to meet. 200. They're all linked to payment, and if you don't achieve the milestone, you don't get paid. So it's true that in 200 milestones, some will be relatively more easy to accomplish than others. I think it's really important to remember that we've each got 200. They can't all be extremely aspirational. There's going to definitely be a range there. And so I think with each public hospital system, there's a range. But the most difficult piece of it is that there are 200, and that we have to transform in all of these different realms at the same time. I think that's really the critical piece of difficulty. Payment is at risk. We don't get the money if we don't perform. That's right. Thank you.
Yes.
I just wanted to come back to the issue of when patients gain insurance, will they stay with their safety net providers? Because I know the experience in Massachusetts suggests they will, but I know that there's a lot of discussion and concern about that. So I just wanted to hear your further thinking about that. And then related to that, I was interested in hearing more discussion about performance measurement. If you think about the IOM, 30% is unsafe and ineffective care, and you're going to not have the same kind of problems of overutilization and treatment in the public health system, perhaps as you do in the private delivery system. But still, there's waste and inefficiency in it. And so I was interested in your thoughts about how the public health systems, in terms of where they're going with data and innovation and integration, what they're doing to track results and to give themselves a kind of a comprehensive view of patient experience. And we've been particularly drawn to thinking about episode of care types analysis of outcomes, adverse events within episodes, cost of care. So I was just, I don't know if that's a clear enough question, but I was interested. We think that it would be such a wonderful thing for the public delivery system to be the public option, and to not only retain current patient base, but to grow it, and to attract commercially insured patients. And so part of this integration and performance measurement and transparency and all of that is a part of that vision. And I guess I just was looking for thoughts or comments about that.
Maybe I'll start and we can kind of play off each other, I think. It seems like we're in this together, you and I.
The end.
Yeah,
okay.
We're in this together, you and I. The question is relative to, one, how do we keep our patients? How do we know whether patients stay? And two, the piece about the performance imperative, essentially. How do we meet the demands of the triple aim and show that we're getting there? And they're actually inextricably linked. So I think the Blue Shield of California Foundation put out a report that was really interesting because it looked at, one, what are people's opinions about the places where they're getting care, the target population of the safety net, to say, are you going to change? What are the things that you're looking for? And it was interesting because they had specific opinions about the public safety net, the private safety net, and whoever else it was that they were getting care at, and they weren't often quite sure if it was or was not safety net. So to the extent that for the patient, and that's why the low-income health program is so important in that experience. If their experience over the period of the LIHP is that there's more forms, longer wait times, and it's more challenging for me to get in and get care, the likelihood of them going to, a Kaiser, let's say, or someone who gives that kind of promise that they will prosper, thrive, is that is that piece of, what's in it for me? And it comes back, though, to our performance imperative and the element of choice. Both LADHS and the community clinics of LA County have put within their strategic plans that they want to be the providers of choice in this new evolving healthcare environment. They also want to be the employer of choice in this new environment. You can't be the provider of choice unless you actually have the staff to do it. But that provider of choice isn't just a question of, do the patients choose me? It's a question of, can they choose me? Do the health plans see that I deliver value for the investment? Do they put me on their roster? Do they make it possible for my facilities to be chosen? Similarly, in LA County, here's an interesting conundrum. If we put these people on Medi-Cal tomorrow in 2014, the network that we've developed between primary care for the community clinics provided at our sites, paired with specialty and hospital care through LADHS, if you transition them tomorrow to managed care, to Medi-Cal, we're not in the same network. The system they get through Healthy Way LA is not available to them on Medi-Cal. And so we have to address that right now to say whether or not we can even be a choice. So thanks to a number of foundations, California Healthcare Foundation, Kaiser Permanente, Blue Shield, we're actually tracking starting to track third next available appointment. That question of, can I get in? Finance, operations measures, patient experience, as well as quality measures, looking at adult preventive measures, hypertension and diabetes, to say, 1, are we making care better? 2, are people experiencing it in a better way? And 3, are we delivering value for the investment? So we're absolutely stepping up, but we have to partner with our public partners to make that happen, because we have to sell ourselves as one system together.
Just briefly, there is so much data that you have access to right this second. If you go onto your computer and look at hospitalcompare.org, you can pick 3 hospitals in your neighborhood and you can compare them on different scales, different types of quality measures and patient experience. So today, that information is already available. Whether or not people use it is another thing. But if the waiver, all of the data that will be reported through the Medi-Cal waiver is even more information in both those different spheres. How well are we investing in ourselves? How well are we providing quality? And how well are we providing the patient experience? I mean, make no mistake, all of this transformation is targeted towards becoming a provider of choice. It's all about being high value and being high social value, being able to provide access to the many more people who will be coming to us after 2014.
Thank you very much. Again, on behalf of Senator Steinberg, I'd like to thank all of you for attending an excellent panel, and also Karen and Gil for convening this very informative, and I believe Karen has some closing comments.
Please fill out your evaluation form. Thanks, everybody. Thank you for coming.
Thank you all.